Good morning, good afternoon, and good evening, everyone, wherever you may be joining us from today. My name is Derek Warnick, one of the co-producers of CME Palooza. Welcome to CME Palooza Spring 2025. Big thanks to everyone for taking a little time out of your day today to join us. We do have a jam-packed agenda today, as usual, so I'm going to go ahead and get started. I'm going to bring up the slides. Starting off with our breakfast session sponsored by MedLearning Group, advancing CME in underserved communities, educating healthcare providers in the VA. Our moderator today will be Tom Bregartner from MedLearning Group. But before I turn things over to Tom, a few announcements for everyone. Of course, recognition of our sponsors. Our gold sponsors today for CME Palooza are MedLearning Group, Medscape, Projects and Knowledge. Our silver sponsors, Academic CME, Daiichi Sankyo, DKB Med, Global Learning Collaborative, Helio CME, HMP Education, MedLive, and Talem Health. And our bronze sponsors, Answers in CME, Bonum Continuing Education, Catalyst Medical Education, CMEology, Excalibur Medical Education, Global Education Group, Infograph Ed, Integritas Communications, Iridium Continuing Education, MedIQ. One more slide. PACE, Paradigm Medical Communications, Peerview Institute for Medical Education, and Vindico Medical Education. As usual, there are two ways that you can ask questions during CME Palooza. You can use the CME Palooza text line to send in a question, 267-666-0CME. You can also use the YouTube chat feature if you're watching on YouTube, or if you want to watch on YouTube, there's a little watch on YouTube on the lower left corner or somewhere on the screen. You can click on that, go to YouTube. I'll be monitoring those questions on both the chat and the text line. Poll Everywhere. We'll be using Poll Everywhere as our ARS throughout the day as our audience response system. You can either use the Poll Everywhere app and put in CME Palooza 005, or you can do it in the web browser. Just type in this URL, pollev.com/CMEPalooza005. Go ahead and get that ready to go now, because I am actually going to open us up with a few questions in just a minute. So you can go ahead and get ready for that as I go over our last slide. This is our speaker disclosure slide. Any opinions, discussions, and or conclusions expressed are those of our panelists and do not represent an endorsement by or a position of their employer, its parent company, or affiliates. Okay, so we're going to do a couple of Poll Everywhere slides to get started. These are some CME Palooza Poll Everywhere questions I put together. Give us an idea of who is watching today. So if you are ready for that. So which of the following best describes your work setting? Are you at a federal or state healthcare agency, medical association or foundation, med ed company, hospital, medical school, medical specialist society, industry, freelance consultant, or other? Sorry if I did not list your group on here. It was going to be a long list. So it looks like majority from, I shouldn't say majority, 50%, half of you are from MEX. No one from industry. Get it together, guys. Come on. All right, that gives a general breakdown of that. I would say that's pretty standard. I would be curious who the others are. That would be interesting. Okay, let's move on to our next one. Have you participated in CME Palooza before? Oh, sure. This is like my 12th time watching. Doesn't have to be your 12th time. I've watched a few in the past. No, this is my first time. Or what's CME Palooza? I thought this was a preview for the NFL draft. That might be more exciting. Not than this session, of course. Just my blabbing on. Oh, very interesting. So it does look like a lot of you have done before, but we have some new timers. That's good. Those of you for the NFL draft. Sorry, Scott will do a session at the end after the very last session. Stay tuned, and Scott will give us his top 5 picks. Okay. One more question for everyone. Who is your favorite CME Palooza producer? Is it Scott Kober? Is it me? Is it Ryan Gosling? Is it Margot Robbie? All who have been CME Palooza producers at one point or another. Shocking news. Oh, good. I am in the lead. I don't blame those of you voting for Ryan Gosling. Although if anyone's voting for Scott, yeesh. Okay, let's end there while I'm in the lead. So at this point, I'm going to turn things over to Tom. Take it away, Tom.
I personally thought I was here for the NFL draft preview, Derek.
I know. Sorry. It's going to ruin your entire session. I apologize.
Thank you for that introduction. I appreciate it. The title of our session here today is Advancing CME in Underserved Communities, Educating Healthcare Providers in the VA. And we'll talk about a few things. We'll talk about why the VA population is an important target audience. Talk about what makes both the patient population and the provider population within the VA unique. Some of the challenges around educating in the VA and some of the unique considerations when educating in the VA. Before we get started, I would like to welcome my esteemed panel and allow them to introduce themselves. So Francesca, why don't you introduce yourself?
Hi, thanks, Tom, and thank you for inviting me to chat at this panel. My name is Francesca Biasucci. I am a grants manager at Jazz Pharmaceuticals, specifically in the oncology hematology space, and we have worked together on obviously more than one program, but specifically on veterans education, Veterans Administration, HCP education. So I'm happy to be here today to talk about those initiatives from the supporter perspective.
And certainly appreciate you agreeing to join us today. Sarah, you want to introduce yourself, please?
Thank you, Tom. So my name is Sarah Hawes, and I am the medical grant director at Med Learning Group with Tom. I appreciate the invitation. I work on the medical side of the business, and I've developed sort of a personal passion for VA education. I have many family members in the military and friends of military families. So it just became a sort of a passion project of mine as I was writing about this group of patients. So I'm very excited to join you today.
We are glad to have you. Thanks, Sarah. So let's kick things off with a question for Francesca. Why is the VA population an important target to Jazz in their CME strategy?
Well, so, as Sarah mentioned, we all, or many of us, have personal connections to VA care. But as far as Jazz as a supporter, it's a framework that we're committed to education to address health inequities. And I think, as many of our fellow supporters are looking to contribute in some way to reducing disparities in healthcare delivery and in health outcomes. And we've all become, very aware over the recent years about how kind of egregious some of those gaps can be. So starting from that point where this is a corporate goal, it aligns with our leadership's ethics and principles. And so starting from there, we look for education that we feel will help increase treatment access across all populations, with specifically underserved populations having to be sort of a carve out that we look for, and education that will equip all HCPs with the latest knowledge and skills. So it's a two-part endeavor, both trying to boost the accessibility of care and treatment outcomes for patients, and also trying to arm, for lack of a better word, the healthcare providers in those systems with everything they need to be able to affect standard of care, up-to-date treatment. So the question from that point is, what are underserved populations? And of course, we can all name many of those, but unfortunately, U.S. veterans are considered an underserved population. And some of the reasons for that are that they face economic challenges. Many veterans are sadly in a space of economic hardship. And that leads to certain things like living in rural areas where costs of living are lower, but there's also decreased access to care facilities. lack of reliable internet services. VA does, telehealth initiatives, and if you do not have reliable internet, you don't have access to that. We probably all also know that veterans have higher rates of chronic diseases, diabetes, hypertension, things like that, as well as certain cancers, and have higher rates of mental health issues, PTSD, depression, and things that can become factors in limiting their treatment success, for a variety of reasons, either because they don't, they're less likely to adhere to treatment plans or to complete treatment plans, or just, for all of those reasons, mental health can be a factor. So it's a really complex system, I guess you could say, looking from the outside, and Jazz just really wants to be a part of making things better in that regard. So why us in this, as far as our relationship that we've had with you? Well, as we've stated, and I know you'll go into in more detail, the veteran population has a higher incidence of certain diseases, some of which are in areas that Jazz feels like we can have a positive impact. And for example, the program that we supported with Med Learning Group last year was in small cell lung cancer. And probably most people know that there's a higher incidence of lung cancers among veterans due to risk factors, some of which are shared by the population, like age. The VA population is older on average than the US population. Higher potential for smoking history, and then also unique to that population is higher risk of having been exposed to carcinogens like asbestos, burn pits, etc. So that's kind of, from the macro level as far as alignment with Jazz goals and mission to care for and improve the outcomes of underserved patients, and then drilling down a little bit as to, why these particular therapeutic areas and what we look for in a program as far as reaching the educational objectives that we have.
Was an excellent answer and very thorough, and certainly appreciate that. And it's true. We've, in our needs assessment of the VA, Sarah, we've identified what makes the VA population such a unique group and a unique audience. Can you elaborate just a little bit on that? Francesca was very in depth, but I think you've got some additional points to add there.
Absolutely. And thank you for teeing that up, Francesca. So looking at pretty much any disease, there is some sort of link to veterans having either a higher burden or a higher incidence. So looking at cancer development in general, which is probably the most well-known, as Francesca mentioned, there are demographic factors. So the current veteran population is older, but that will be changing over time. But currently, the biggest chunk of veterans are white males over 65 years of age. And then not necessarily age, but there's also a high frailty score within there and multiple comorbidities, also including cardiovascular disease and chronic kidney disease. And there's also a heightened prevalence of smoking, which is actually sort of a historical factor from back in probably the Vietnam War, when cigarette companies would send free cigarettes to the veterans. And that's sort of persisted through today. But then there's also the presumptive service connection. So these are, I believe there was legislation in 2023 in which they expanded access to VA benefits for veterans who had certain exposures or risk factors that they attributed their disease to exposure to that. So the main ones in there are exposure to Agent Orange. So this happened with Vietnam War veterans, but then also veterans who served after them, but had exposure to the equipment used to transport or store Agent Orange. Burn pits, these are more common in the more recent veterans in the post 9/11 era in Iraq and Afghanistan. There's also exposure to ionizing radiation. So this was commonly in the atomic war veterans, but actually now more recently, we're realizing that the pilots in the Air Force are flying at a higher altitude than commercial pilots. So they have higher exposure to cosmic radiation. There was also, some of you may have heard about the Camp Lejeune water contamination. So that not only affected veterans, but their families who live near the bases. And then there's also just other occupational carcinogen exposures, such as asbestos and radon, working in these conditions. It's also important to know that the VA population comprises of like 9 million veterans. And that's actually only half of the veteran population, because they need to qualify for VA benefits or actually use said VA benefits. And so it's not necessarily the veteran population as a whole, but the veteran population being served at the VA have been classified as a clinically complex patient group. So as Francesca said, it's a complex group of patients to start with. And as more veterans, as they start expanding benefits to veterans, like the PAC Act did for veterans exposed to any of these carcinogens, there will be a higher demand for VA services. So even though they're anticipating that the veteran population will decline in upcoming years, the demand for resources will increase. So we'll still have a need for continuing education and resources at the VA.
Thank you for that overview. So that's a good description and a good overview of the patient population. Sarah, what about the healthcare provider population within the VA? Is there a uniqueness in that population as well as compared to the general healthcare community?
Yeah, certainly. So I think like when we talk about the VA in general, the biggest issue is a lack of resourcing. So I think even as early as like in 2022, there was a 23% vacancy rate for their clinical staff, and 91% of their facilities in the COVID area were considered at a severe shortage of nurses. So they've historically and continue to be under-resourced. And there's a surge of demand with growing awareness of conditions and benefits that the veterans can contribute to. We also hear that there's a lot of like EHR inefficiencies, and it's very difficult to work with the electronic systems in the VA. They're older. They're not necessarily as intuitive as other healthcare systems. And it is the largest integrated healthcare network. So global inefficiency is a huge issue in delivering medicine. But I wanted to focus today on what we can accomplish in CME, perhaps. So one of the things that we've seen with oncology in particular is that the VA clinicians said that they have very low awareness of clinical trials in order to get their veteran patients enrolled. And they just struggle with the bureaucracy of getting them to that. So there was one paper that I referenced here about barriers to inclusion in oncology clinical trials. So there were certain gaps that they found, that challenges that the VA clinicians had. They were unfamiliar with clinical trials that are available. They have clinical trials within the VA, but also beyond. And there's also uncertainty identifying veterans who may be candidates for these clinical trials. A lot of times they sort of assume that a veteran might not be a candidate based on age or comorbidity. So they automatically assume that's not a venue for them. And they have attributed a driver to that as just a lack of time, resources to actually do the research, and the preconceived notion that their patient wouldn't be eligible for clinical trials. As I mentioned, there's a lack of resources for veteran education. So how to educate the patient on the benefits and risks of clinical trial enrollment. And they've noted that even among veteran patients, they face this misconceptions and hesitations about clinical trial enrollment due to a historical lack of trust in the medical community, which still persists within veterans. And there's also logistical and financial barriers, as Francesca mentioned, veterans that live in rural areas that don't have access to clinical trial sites. And there's also just difficulty coordinating entry and access to clinical trials. They have trouble understanding the referral process of getting a veteran into clinical trials, and then inadequate support for the veterans who may be eligible but don't have the logistical or financial support to continue in a clinical trial.
It's excellent points, and that's why when we look at educating healthcare providers in the VA, it's an important target audience. So MLG has been able to do that. We've had a unique partnership with the VA that allows us to educate providers in VA centers around the country, not only live, but we have access to the Vision network, which is allows us to simulcast out to a broader audience. So when we're presenting a live grand rounds within a VA center, we can reach multiple centers throughout the country, which is an important way to reach a broader audience, reach a larger audience within the VA. And we really tailor our education to those unique needs of the VA and the VA healthcare providers. What we've seen within the VA is that VA clinicians overwhelmingly respond positively to innovative methodologies of education. Education that includes visualization of hard to grasp concepts around new and emerging treatments, diagnostic criteria, guideline-based treatments. These are the types of education that we're targeting or we're rolling out to the VA population. It's also important for the VA clinicians to have access to tools and resources that they can utilize post-education to reinforce their knowledge and their competence gains and utilize these tools in practice. We found those types of add-ons to the education to be incredibly successful. We have a question from the audience. Are there any topics that the VA asks for? I think, Sarah, I don't know whether they ask for it, but we've identified it with our needs assessment. Sarah, I think, you kind of touched upon some of those areas, but have we, when we're doing our needs assessments, are we seeing any, particular need on topics for education?
I think the standard, so the ones that with the known increase in the veteran population, so as Francesca mentioned, small cell lung cancer, any form of lung cancer, really, any of the oncologies, the mental health, PTSD, TBI, so pretty much anything that would be a higher risk in the veteran population. And they do mirror the general population in terms of most common diseases, so we'll probably start to see more requests.
Yeah, and that's a good point. And this is a great question too, because through our partnership, we do have fairly regular planning meetings with the VA, where we're identifying topics to discuss and topics to educate on. And so, as Sarah mentioned, the things that come up are pretty are in line with the general healthcare population. Again, with a slant to access to clinical trials, updated data, updated clinical guidelines, those areas, those topics. So, as Francesca mentioned, we conducted an educational initiative on small cell lung cancer in the VA, and what we saw from our outcomes it was not a surprise to us, having so much experience educating the VA, but is slightly unique to the VA as compared to the overall healthcare community. We find that our baselines are a little bit lower than the general community, particularly when it comes to those areas of updated clinical guidelines, updates to data on new and emerging therapies, current and ongoing clinical trials, so the outcomes we're presenting here are in line with what we've seen in the VA when we're educating on a broad scope of topics. We have another question from the audience, and this one is certainly directed at Francesca. Francesca, how has leadership at Jazz viewed, I'm assuming, this differentiated program, meaning the unique considerations of educating within the VA?
I guess I'm not fully understanding the question. The word differentiated, not fully understanding what the questioner is asking. Maybe they could elaborate. I would take a stab at it, but I'm not quite sure where to start.
Fair enough.
Yeah.
Whoever asked that question, if they could, provide some color around that would be great.
I think maybe you could just talk about just in general how the leadership at Jazz has looked at the uniqueness of this program compared to other types of programs that you
Okay, great. Well, I was going to say, I think sort of as the grants manager and the person who gets the first look at outcomes for all of our supported programs in these areas of oncology, hematology. I won't speak specifically to this program, but in general, a close look, I give a very close look and try to relay to my internal stakeholders exactly what Tom is kind of giving us the shape of, which is what are the differences we might see from a different program that's not VA associated. Are the baselines lower? Are the baselines higher? Are there areas where they seem to really struggle and others where they don't? And I think what he's mentioned are things that are, stood out to me as well. Not so much the lower baselines, I'm not sure, but also, knowledge about emerging evidence, new data, changes in guidelines, and things like that. So it's really important for me as a supporter to try to do a side-by-side comparison, because not to kind of, shine a light on what's wrong at the VA, which I think there are many things that are right at the VA actually that we can learn from, but to be able to hone what I'm looking for the next time, so it's not the case that just sort of a program that would be relevant to healthcare providers in the private sector or the non-VA is actually going to work in the VA. So I want to see a design and also, an agenda and learning objectives that do relate to what I know from having seen outcomes from programs like this, are areas of educational need. So I think that's kind of the program. It does differentiate, what I'm looking for the next time around to try to build on the success of and make sure that we're covering, where we know the gaps historically have been more noticeable.
I think you did a fantastic job of answering a difficult question. We have another question from YouTube, Derek. Are there any challenges accessing VA clinicians specifically? Are government contracts required? It's not so much government contracts, but there is an approval process and a vetting process within the VA that you have to, as a provider, you have to be approved by the VA and the VA educational network in order to be able to offer education within the VA. Certainly, general education online is available to the VA healthcare population, but it really requires a partnership with the VA. Again, understanding what their needs are, and working with them to gain access to particular VA centers. As I mentioned, the VISN network. So there is an approval process, but MLG works very closely with the VA to offer education that is needed and impactful for the VA population. So we talked about the quantitative data that we saw. When we look at some of the qualitative data, it's interesting. It seems to be along the same lines of what we're seeing with the quantitative data, around guidelines, around updated data. There's concern or questions around the uniqueness of the VA patient population. But what's interesting here is the running theme across all of these questions, or across a lot of the questions that we see, and these are questions asked within a grand rounds program in asthma. We see that the VA clinicians seem to be benchmarking themselves, or trying to benchmark themselves against the greater health, or the more general healthcare provider community. Again, with questions like, do the amount of VA patients with asthma correlate with non-VA patients? Is non-adherence a more common issue in the VA environment versus the greater healthcare community? So there seems to be a recognition, or there is definitely a recognition within the provider community that the VA is a unique healthcare setting. I mean, Sarah, it kind of goes along with what you were, with the work that you've done in identifying the need. Are you surprised by the fact that they recognize their uniqueness?
Oh, no, not at all. I think they all realize that just like in their military service, they're working in unideal conditions, and they have to work with what is available. So I do have to say that, like, especially in the lung cancer field, they actually exceeded the general practitioner rate of lung cancer screening based on the U.S. Preventative Task Force recommendations. So they are somewhat competitive in that aspect, but it gives me a sense of optimism that they really don't see their lack of resources as a limitation, and they leverage as much as they can from what they are provided. So it's optimistic in the CME world, because it seems like a little bit of education could actually go a very long way, and they're very thirsty and hungry for this knowledge. They also want their patients to have the same outcomes that the general population does, even if they're given less resources to provide those enhancements in patient care.
Do more with less, right? That's
correct. Yeah,
that's the general outlook in the VA community before they were veterans, right? And certainly within the veteran population, it's and the VA system, it's do more with less.
absolutely.
And Francesca, I think that provides a unique opportunity for commercial supporters to support education within the VA, right? Knowing that what we're going to provide is going to reach such a broad audience, and a thirsty audience that is going to make the most of it. It puts our supporters in a unique position, right?
Yeah, I would say that, it's funny, so many things that you guys have both brought up in this conversation just have, resonated with me and brought back memories. When I was a student, I was a physical therapist for many years, and I did a rotation at an inpatient Veterans Administration facility. And as you say, so I have so many memories that link to this. Now, that was a long time ago, but I remember walking into their file room and just seeing walls and walls of paper files. And even then, things were transitioning to EHR. We didn't have Epic in those days, but things were moving. So, there were equipment, there was equipment that we worked with. This was orthopedics, of course, with prosthetics and things like that, but decades, older than what you would encounter and use in the non-VA system. And yet there was such a kind of a mission mentality, and we had all the time in the world, which is not something that I ever encountered again in my professional clinical work. So that, I don't even know if I would call it less. Yes, they're not all the advantages of kind of cutting edge technologies within the VA system, and true that resource allocation can be spotty. I think there's different resources available at different VA facilities. And of course, as we know, kind of federally, there's challenges continuously with funding. But absolutely, I think there's many things about the system that are positive, and I have a few stats to back that up. But but yeah, so I think as a supporter, it kind of just gives you even more motivation to kind of get supply whatever tools we can, to sort of as compounding interest. They're doing a really good job, with what they have, which is some real pluses and some challenges. And so whatever we can do to kind of augment their success, it helps sort of focus our attention and makes us aware of how valuable everything that we do is that can be a support to them, their system, and their patients.
So do the insights that we've presented and the insights that you've gained through the programs that we've done with the VA that Jazz has supported, does that have an impact on Jazz's approach or your approach to education in the VA?
Even from this conversation, I think some things, it's sort of like continuous learning, of course, on my part. Not, talking to you guys, hearing your feedback, hearing your experience. We chatted a little bit before, this presentation came together, in which I learned some of the limitations and challenges or not around educational design and what can be implemented, in the VA system because of technology sometimes, or just access and their capabilities. So even today, I have jotted down a few notes about, really wanting to focus in on a patient education piece. I think we do focus a lot, or I know I personally think a lot about how to, bolster the knowledge and competence of the healthcare providers. But if there's a way, I should probably pay a little bit more attention to, activities and pieces that are focused toward the patient themselves. And so, I've learned things here that will sort of refine what I'm looking for as a supporter. I will also say that in my reading and thinking, but mostly my reading for this presentation, I came across many papers, as I'm sure did you guys, that where the VA system has been researched as a model of healthcare delivery, because there is it's a different structure than we encounter in the non-VA world. And they have had some real successes. And I can say from my experience there as well as a healthcare provider that there's a much more holistic approach to patients. And so, you're not only treating the symptoms or the physical, functional issues or the medical issues, but there's transport, there's attention to clothing and housing and transportation and mental health and all kinds of other things that are bundled into that kind of holistic model of care. And it's been shown, studied as an alternative to the system that we live in and shown to be successful. And I just wanted to throw out a few stats because I think even myself, based on my personal experience and also just kind of the general sense of what the VA is like and how difficult it is and how much they're struggling, is that things are going really well for them as well. And I feel like I understand more that it's that we have a bilateral educational relationship. There are things that we can learn from them. I can learn from them to potentially inform, programs that I can support or consider for the non-VA system populations. So a couple of stats that I found really interesting from 2024, so very recent. In patient satisfaction surveys, VA hospitals consistently outperform non-VA hospitals. CMS rated 58% of VA hospitals 4 or 5 stars for quality compared to only 40% of non-VA. So that's patient satisfaction as well as, an external entity giving that rating. And in 2024, this one really struck me. Veteran trust in VA outpatient care reached an all-time record high of 92% based on a survey of more than 440,000 veterans. And I'm sure, I don't have the numbers, but I kind of doubt that there's any, non-VA corporate healthcare systems that would rise to the level of 92%. So, I feel like this has just kind of sharpened my thinking a little bit about, like I said before, how everything we do can sort of help support this sort of holistic and in ways very positive model of care that they are implementing and have the unique ability to, because they're federally funded and have a different kind of they have different goals than maybe private healthcare. And so also I think, that perhaps, as I said, we can derive insights ourselves as to where they have unique successes that we can learn from and maybe try to mirror back in some other ways. So I feel like what I take away from this is I have a lot to learn from the VA, and what we do to support them is so important and so appreciated, and that they are sort of eager learners. And the more interesting and engaging we can make our education, particularly now when there may be additional financial or budgetary and staffing, as we know, and I think you mentioned, Sarah, staffing challenges, we'll just continue to look for ways that we can, bring education to them and that it will help them serve their patients better.
Those statistics are pretty incredible, and I would agree with you that I doubt very much that the general population in the healthcare community has a 92% satisfaction rating. So
yeah.
Wow, that's pretty amazing. We have a couple of questions from the audience. First, do you think with the recent budget cuts that independent and other forms of education will be needed? And how can the overall CME community help? I'm just going to throw this out there. Do either of you want to jump in on that?
Absolutely. I mean, we were preparing for this question because I think that is the question. Like, what will happen to the VA if there's no more VA? Where will the education go? And I think they will, as Francesca said, they're a mission-driven organization. They will make the most of what they have. And so I think now that their funding is less coming from the federal government, we should step up as a CME community and see where we can support and help them maximize what they have.
Francesca, agree? I mean, is it an opportunity for us, or?
Yeah, I mean, the staffing part, we can't do anything about, of course, but the education part, I mean, I think we're all probably proud of the fact that IME is free, and that we are already offering an educational kind of pathway that is no cost to them. And I know internally there has been, at least historically, that as well. So, maybe it is a signal to us to sort of step up not only maybe the amount of education, if they're going to lose some of their internal resources, so pay attention. So, we can pay attention through our, participation in other organizations that, give us insight into what's happening at the VA. And also, I don't know, maybe it will drive some, need to look for unique formats or delivery, delivering activities in ways that we haven't had to do before or thought to do before as a way to continue reaching those clinicians. So probably we should all keep our eyes open for being aware of what the changes are and how it might affect, our program development.
We have a question that seems to be more geared toward me as an outcomes role, but in the question is, in all your experience measuring education in the VA, have you seen growth amongst the learner population? I think the answer is most definitely, but in the areas of need, we're talking about rapidly changing scientific landscapes, and so it's the I think it's the old adage of 2 steps forward, 1 step back, and it's not that they're taking, they're not gaining knowledge and competence. It's that the areas where the knowledge is needed is changing, and so it's that challenge to stay current and stay on top of the most recent advances within the therapeutic landscape. Sarah, there's a question that doesn't seem to be related to the VA, but I think you can probably put a VA spin on it. What advice do you have for writers who do not specialize in oncology on oncology needs assessments, and if we can tie that to sort of identifying the unique need in the VA, I think that would be within the scope of this discussion here.
Absolutely. So I think talking about oncology at the VA, I think you need to be aware that there are special risk factors that the veteran population has that other populations do not have. So definitely need to acknowledge that. You need to acknowledge what we said before about a lack of resources at the VA. So that means, yes, I think we all strive for the interdisciplinary, multidisciplinary care, but that might not be feasible within the VA. There's fewer physicians, so the same physicians wear the same hat. So you might have to think outside the box about the type of education you provide, because it's not simply like within the same center, you might not have the same type of specialists or just even access to the specialists at all. So I think you just need to consider the unique risk factors for the veteran population, as well as how the framework of the VA, and just knowing that one physician's wearing many hats.
Awesome. There's another YouTube question that came up. Do you think there are learnings we can apply to other settings? I wonder if there are learnings in terms of federal funding constraints we can generalize to publicly funded systems globally. I mean, you touched upon this a little bit, Francesca, that, well, a lot of it, that there is a lot to learn from the VA. But, so in your experience with, particularly related to CME, are there things you think we can learn from targeting education within the VA?
Can you drill down a little bit? I don't want to repeat what I've already said. So
I think there are things that we can learn as far as the types of education, the educational formats that are effective. I don't think the VA population is incredibly unique when it comes to which educational formats are impactful, right? Sorry, you're shaking your head like you have things to add.
Yeah. No, I think we could all learn from the VA model of find a problem, fix the problem, find a problem, fix the problem. So they did it very well in lung cancer. They, their screening rates are well above the national average. They had a problem, they fixed it. Something I was reading about last night was the Reboot initiative, where they realized that these lack of resourcing, a big issue was clinician burnout, and especially during COVID. So that was not unique to the VA, but they then did put the initiative forward to help address clinician burnout before clinicians were making less money at the VA. And so that contributed to the resources constraints. And now the salaries and reimbursement is more competitive. So I think just in general, we can probably just look to them and their model of find a problem, fix a problem, and apply that to all their large healthcare systems.
You know, I'm going to bring up one other thing that I just thought of when you were talking, Sarah, because thinking about what they're doing internally, screening rates and things like that, that are actually attaining higher levels than in the private healthcare system. And one of those things, which I find super interesting, because we're talking about addressing health disparities, outcomes disparities, and also underserved populations, is that, and this is a little bit of a house of mirrors to think about, but within the VA system, the outcome disparities are better. You know, I mean, there's fewer, there's less difference in outcomes, but let's say between their minority population and the white population, for example, than outside of the VA. So clearly they are having successes at addressing some of the sort of chronic systemic problems that we have in the private sector. And again, I don't know how we kind of, learn from them exactly how to address those things, but there is this sense of like, as much as we feel like we are in this position, and we are to some degree to educate them, we also need to kind of be taking in what they're doing that maybe can help inform our own, there's only so much we can do as IME providers, but whatever we can learn from their models and their processes. It seems like the more you read about the VA system, the more that is there to kind of, continue inspecting. So we just try to amplify their successes internally, but they're having many, and I think that should be recognized as well, as we are here today and has come up in our conversation.
We're coming up on time here, so Derek, are there any other questions that have come through?
Let's see, no questions. Let me bring this up. I thought this was interesting from Brian. Just a little bit of a history lesson talking about how some of the pioneers of CE CPD in the U.S. got their start in the VA system mid to late 1970s, where they were hiring a lot of first-generation PhDs, educational doctorates, etc., in adult learning as part of it. I'm sure if anyone wants to talk to Brian in more detail, he'd be happy to give you an entire session on that. And then just a nice thank you here from Phil to everyone on a great session. That was really great, guys. I appreciate everything that you did. I'll wrap up with my final slides, but Tom and the rest, any final thoughts before I wrap up?
Just thank you for the opportunity today, Derek, and Francesca and Sarah. Thanks for joining me, and hopefully everybody out there in CME Palooza land learned something and found some value in this.
And hopefully they weren't too disappointed that it was an NFL draft. Okay, very good. So first thing is we have a CME Palooza scavenger hunt going on. I think actually Scott just sent out a blog post about it around 9 o'clock. So more details on the CME Palooza website. Big thank you to ACHL for sponsoring. Basically, go to their website, look for the CME Palooza logo, and click it. I'll be honest, I don't know what happens when you click it, so it'll be a surprise for all of us together. Second thing is we do have a survey that we asked everyone to take if you can. It's on the live page of the CME Palooza website. There's a link there for the survey. Just helpful for us to know who's participated, what topics you're interested in. We do use that information as we're planning subsequent Paloozas, so please do that when you have a moment. And then lastly, to view the next session, which will start right at the top of the hour, let me get my agenda. Just click on the link beside the 10 a.m. Eastern session, which will be Pineapple Pizza and CPD, Mixing the Right Ingredients for Success, sponsored by Academic CME and Helios CME. Just for reference, pineapple on pizza is terrible. So we'll see how that session goes. So make sure you do that at the right at the top of the hour. So you have a few minutes to go grab yourself another cup of coffee. Again, Tom, Francesca, Sarah, thanks so much for the session. Thanks everyone for watching, and we will talk to all of you soon.